Okay, coming to the final session for SEOUL Valve 2025. Together with Myeong-Ki, we are going to chair this session with our esteemed panelists here. So I think without further ado, we're going to just go over to Asan Medical Center. Hi, Toru.
Hey, hello.
Hi.
Hi, how are you? Welcome,
Good.
welcome. And so, good afternoon in the audience. And this is really our last two complex live case. I would like ask the audience and don't go home. The last two cases really too much complex. Is a climax case in this year's SEOUL Valve. So we are the last two cases prepared. The valve in valve case and TAVR in TAVR case, and as you mentioned, we have lectured a lot of valve failure, TAVR in TAVR, and the overall proportion of TAVR in TAVR is growing up. And the last two cases, we are different combination TAVR in TAVR valve, and this is relatively simple. And the second case is much the complex case, and we'll present S.J. Park. So. I'm D.W. Park and 수연한 우리 승한 Lee. Okay, can you present the patient background?
Thank you, Professor Park. Let me introduce this case. We have a 79-year-old female, and she was admitted for dyspnea, functional classification 2. She underwent TAVR 4 years ago for aortic valve stenosis with SAPIEN 20 mm. She had the previous PCI history 4 years ago at mid-LAD. She had diabetes, hypertension, and her BMI was 28, and her SGS score was 6.5%, and her Euro score is 2.0%. EKG shows sinus rhythm. Chest X-ray showed cardiomegaly. Echocardiogram showed normal LVEF function, and aortic valve area was 0.59 centimeter square, and mean pressure gradient was 45 mmHg, and maximum velocity across the aortic valve was 4.2 meter per second. 4 years ago, after the first TAVR, the Vmax was 2.9 meter per second, and mean pressure gradient was 19. But as you can see, recent TT showed that the flow acceleration and the limitation of the custom limitation, motion limitation. And T showed that the echogenic mass on the strut of the prosthetic valve. It's concluded that it is feasible for degenerative severe AS. And this is the previous implanted TAVR valve, SAPIEN Ultra 3 20 mm. This is the pressure gradient pre and post TAVR at the time. And as you can see, much improvement of the pressure gradient. And her indexed EOA was 0.78, and she is in the moderate grade of the PPM, patient prosthesis mismatch. CT finding shows that the annulus short diameter was 18 mm and long diameter was 19 mm, and annulus area was 271 mm square. Sinus to annulus area ratio was 1.64, and SU junction to annulus area ratio was 1.35. LVOT to annulus area ratio was 1.15. coronary height was sufficient. And then valve coronary is left side is 3.3 millimeter and the right side is 5.0 millimeters. This is the annular projections. And left side, CIA have luminary, but the right side of the iliofemoral artery is feasible for transfemoral TAVR. And this is IV siding chart for SAPIEN 3. And this is the siding chart for evolute effects. So recommended evolute effects prediction of TAVR in TAVR is just 0 to 1 millimeter to the previous TAVR valve. And this is our final plan.
Okay, could you show us the last pressure gradient just immediate post TAVR? And we have a very nice discussion point. And this patient just 4 years ago underwent SAPIEN 20, the lowest, smallest size. At the time, even after post TAVR, the pressure gradient was absent. It's a SAPIEN 20 is very successfully implanted just 4 years ago. At the time, we checked the indexed EOA, and the indexed EOA was by definition 0.78. There was a category in the moderate ppm. So, and we have a lot of discussion point, and some physician did not prefer the SAPIEN valve 20 because of such a durability issue. So we will have a discussion point in the SAPIEN valve 20 size. Is it a matter for durability or any many the opinion from the audience and the panel would be possible. So we will have some discussion time for this case.
Okay, so the question is whether going back to first TAVR valve, whether should have used a 20 or obviously using an evolute at that time. So, obviously at that time you don't have any of the smart data of anything that is really looking at small annulus, and we also used 20 millimeters at that time, but I think since that time we have pretty much given up on the 20 millimeter SAPIEN valve. So anybody in the audience actually still put in 20, or you would just go with the self-expanding?
For me, I did not use the 20 and SAPIEN is too small. So I'd like to ask this kind of phenomenon is a common phenomenon or is some specific phenomenon? Because this is the typical example for especially in the Asian female patients, small size of it. So everything is small and a clear indication for the smart trial. So a lesson from these cases, 75 years a female patient, and then we deployed the SAPIEN valve, and the expected valve area at the times is 1.15, even though after the TAVR small valve area. So this is a lesson. So what can we do in the initial same patient?
Yes, that is a good debate point, and we are invited the panel from the Japan and the Toru and the Shinichi and the Euihong and is much have experience of SAPIEN 3 and the 20 small size in the resilient tissue. And any thought about do you have a similar experience like some very short duration of durability? This patient 4 years. Yeah.
My name is Shirai. So I also have experience about 2 years after implantation that the valve was damaged. So the patient was implanted 20 millimeters valve because of the lung cancer, before lung cancer. So, but after operation of lung cancer, she was diagnosed cured. So, and I asked the surgeons to valve a surgical valve implantation. Yes, it's very usual. 20 millimeters valve. Yes. But so SAPIEN 3 ultra resilient is maybe the more good hemodynamic status. So, but so SAPIEN 3 20 millimeters it's a high risk of poor hemodynamic status. Yeah, I also experienced same situation. Yes.
But this is not a Resilia though, right? This is a 23.
Yeah, right.
Yeah, because it wasn't available probably at that time. But the funny thing is that, have PPM, no question, somewhat PPM, but will it accelerate the degeneration of the valve, right? Because, this valve clearly has degenerated and not just, have a small valve. So that's always an interesting question. When the valve gets too small, does it really somehow hemodynamically accelerate degeneration?
Absolutely. Yeah, absolutely. Yeah. So we are the reason why we wait here long-term follow-up data in the SMART trial. Although Partners 3 trial, there was no big difference according to the size of sapien valve 23, 26, 29, but still many interventional cardiologists, especially in the Asian Pacific area, we have many small annulus patients. Is concerned about that put the small valve, and there is some concern about the long-term durability. And this case is some typical case.
So,
okay,
so in terms of looking at putting in evolute valve, you are looking at a couple of things, right? So these leaflets will pin up to the top, almost to the top of the valve, at the commercial tap. So your coronary wrist plane is pretty low. So are you concerned that obviously there's room to go for blood to go around, essentially?
Yes. So it's very luckily, and this patient has a coronary height is not too small, and more than 10. Also VTC is feasible. So first we are just do small size balloon and for pass out past the envelope valve, and we're gonna use 14. Yeah. And okay, 이거 프레셔 연결해야 되나? Okay.
Professor D.W. Park, this is the Euihong call. So
Okay.
this is a valve-in-valve case, so you are using a sentinel or cerebral protection?
Yeah, and we are frequently use sentinels now. Is we don't have we don't use it for this patient, but this patient is as you mentioned yesterday, Myeong-Ki Hong is one of a high risk patient, and sometimes we do, but we will ask a patient for permission for the use of the sentinel, and this patient disagree. Okay, this is 14 GMAD balloon. Okay, here. Okay, 여기 됐고. 할 때 쏘자. 자, 천천히 준비됐지? 자, okay, pacing on. Okay, inflate. Push. Okay, 됐지? deflate. Okay, 자, pacing off.
What size of the balloon?
It's just
Why it is not expand to the valve border?
Yeah, so and I think usually if you usually we are select a much smaller size, and because of still we concern about the coronary obstruction, and we are just avoid valve passaging failure, and sometimes the valve failure is very sticky, and even though catheter does not pass well, and I think we can expand the envelope valve if there is some remain expansion, the non-uniform expansion. We will do post dilation.
I think it's the characteristic of the valve degeneration in this patient is different to the other cases because of the duration for the symptom onset is only 4 years.
We have a 3 class, and then the slide area 한번 해볼까?
It'd be nice to go with the bigger balloon and check the coronaries as well, like our Japanese colleague, I think Dr. Yamamoto was talking about. Because I'm not quite sure, the coronaries are quite low. I thought he said the
지금
valve
3시간 이렇게 하고
the
있지?
coronary wrist plane was high, but I thought it was low.
이렇게? 오케이. 지금 괜찮지? 오케이. Make sure hand mark is lateral part. 오케이. 위에 보여주고. 오케이. 자, passive oblique view. We will deploy the passive oblique view. Seung-Jung. We would like to match the distal part of the same level in the previous sapien valve. 준비했지? 네. 오케이. 잠깐만. 요거 이제 수연이가 풀어보자.
The goal here is
Okay,
supposed to put
준비됐지?
a third node of the FX or the
야,
evolute
여기서 한번
to the top
120.
of the
오케이.
sapien
릴리스 한 바퀴.
tap. So
릴리스.
sometimes it's difficult to count exactly where it's the third
Release.
node, but
천천히. 자, release.
generally the valve kind of sticks below
오케이.
the
릴리스.
sapien valve a little bit
오케이. 릴리스.
because the evolute valve, the
Okay,
valve starts at the
release.
third node. So you want it to stay above,
네, 천천히.
if possible, the
약간 이걸 일로
small
옮겨줄까?
sapien 20.
릴리스. 오케이. 릴리스. 기다려. 릴리스. 혈압 찌면 얘기하고. 오케이. 릴리스. 오케이. 릴리스. 120. 오케이. 릴리스. 기다려. 오케이. 릴리스. 오케이. 릴리스. 야, 들어간다 이게. 오케이. 릴리스. 오케이. 릴리스. 쭉 풀어봐. 오케이. Yes. So, 오케이. 혈압. 자, 그거 풀고, 펜싱 풀고. 풀어. 오프. 다 풀었지? 이렇게 좀 혈압 올 때까지 기다리지. It's more deep, slightly deep dive at the time of the initial inflation. 오르고 있지? 다시 한번 감았다가 다시 풀자.
I think that this is more better than this is some negotiation balance between the
Absolutely,
risk of the permanent pacemaker
Yeah,
or
right. Yeah.
if you more pullback is there is the risk of the coronary obstruction.
감아.
So I think it's
감아. 쭉쭉 감아. 자, 혈압. 자, 페이싱하고. 백업하고 60. 쭉쭉 감아. 쭉쭉 감아. 오케이.
I think you need to
감았지?
deploy a little
자,
higher. Yeah.
괜찮지? 조금 기다리고. So I would like some make strength the grip, but it's at the release point it's very forcefully it's
Yeah.
deep dive. 자, 천천히 한번 해보자. 자, 여기서 자 120. 자, release. 자, release. I push the wire in the LV. Release. 잠깐만. 자, release. 자, 커시브 올리피 맞지? release. 오케이. 잠깐만 좀 더 들어가야지. 오케이. 자, release. 자, release. 천천히. release. 어느 포인트에서 이게 확 들어가거든. release. 혈압 떨어지면 얘기해줘. 자, release. 꽉 잡고 있을게. release. 자, release. 오케이. release. 혈압 떨어지면 얘기해줘. release.
Yeah, now you come back a little
오케이.
bit.
release.
With the dive.
오케이.
Yeah.
release. 오케이. 좀 쭉 풀어봐. release. 야, 이게 밀려 들어가. release. 혈압 오를 때까지. 자, 쭉 풀었지. 자, 백업 그거 줄이고.
okay, check it with an angiogram.
오케이, got it. Would you like? I would like some exact positions, bottom line, but is there a possible diving? 오케이, 여기서 한번 찍어보자. 지금 혈압은 괜찮지? 네, 혈압 괜찮습니다. 오케이. 자, 여기서 한번 찍어보고. 자, 풀샷. It's good. 절로 에리어.
Actually, the valve size is small, so therefore,
Yeah.
after the deployment of the evolute valve, you may have a chance to the post still. So you have to think about that. And therefore, I think it's the low margin of the evolute valve is a little bit deeper, but still I think it's the acceptable
Yeah,
for
I think
me.
still much different than our initial intention. But we have a negotiation. One more time I try, and if the similar things happen, I will release at this point. 한 번만 더 커시브 오브리프에서 한 번만 잡았다 한 번만 더 넣지.
Right.
자,
Would be
okay,
nice a
one
little
more
bit
time.
higher.
Yeah, absolutely. 자, 커시브 오브리프 맞췄지? 자, 아직 페이싱 안 하고 있지? 여기서 빨리 감자. 자, 쭉 감아. 그렇지. 쭉 감아.
You know, the native degenerative valve is very sticky.
Okay,
That's why, pre-dilating with the bigger balloon to help
쭉 감아.
release
더
some
감아.
resistance is helpful.
끝까지
I know
감아.
that issue of AI, but you know, you do it fast, it'll be probably okay.
오케이, 됐어. 잠깐만. 자, 혈압 오를 때까 조금만 기다려. 천천히. 자,
Pressure comes back pretty good,
한번 해볼게. 자, 120. Release. 오케이, release. It's slightly upper position. Release. Okay, release. Okay, release. Okay, 자, release. Okay, release. Okay, release. Okay, release. Okay, release. 혈압 떨어지면 얘기해줘. Release. Okay, release. Release. Okay, release.
Good.
Okay, release. Okay, release. 자, 쭉 풀어. 쭉 풀어. 오케이, 오케이. 자,
Faster.
혈압 떨어지고. 오케이, 됐고.
Good,
이제
good.
페이스
Better, yeah.
됐다. 혈압, blood pressure is okay. Okay, got it. I'm gonna. 자, 지금 괜찮지? And the much upper part. 이제 한번 찍어보자. It's good.
Good.
I think position is much better. area.
Yeah.
오케이. 자, 우리 3코스 뷰. 자, 여기 찍어보자. 오케이. 그죠? Okay, good. So, I think that is the
Good,
best
good.
attempt. Yeah, we are the release over here. Okay, 천천히. 자, 여기서 다시 페이싱 해봐. 120. 자, release, release, tension relief, release, 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 release.
More slowly.
천천히 기다려. 기다려. 좀 빼고 해도 돼. release. 오케이, 기다려. 자, release. 오케이, release. 오케이, release. 더 release. 다 나왔지? 더 release. 하나,
Yeah.
오케이,
Okay,
됐다, 이제.
good.
오케이, I'm
Excellent.
gonna, yes. Remove the tension. 오케이. 오케이, good. 오케이, 그냥 120배 꺼봐. 이렇게 하고 한번 넣어보자. 자, 요 시스는 놔도 되지? 자, 좀 요거 디센딩 보여주고, 오케이. 자, 여기서 이제 여기서 붙여. 자, 요거 이렇게 하고 쭉 뒤로 밀어야지. 그렇지, 그렇지.
Myeong-Ki, would you consider
자, 뺄게. 자,
automatically to
Okay, 1, 2,
post dilate
3,
at this point, or do you want to check the gradient?
됐지? 자, we're gonna check a gradient
For me,
first. Okay, 1, 2, 3.
in this case, I will do the ice and check ice
1, 2, 3. 1, 2, 3.
and do it everything and hemodynamic looks anyhow. There is a surrounding. There is no severe calcification.
Yes,
My
yes.
personal bias, it does not need the poster. And anyhow, confirm it.
Yes.
And the
We're gonna check
rotational
out the hemodynamics.
fluoroscope and the others
Yes.
and the hemodynamics.
Okay. 다 잡아. So, and because of prior size is very small, so although I would like a position, proper position, at the time of deployment is very possibly diving to the elbow portion. Okay.
The procedure itself is excellent, and what is your expectation after the second valve, the effective the orifice area of aortic valve in this
Yes,
case?
first hemodynamic, invasive hemodynamic is we're gonna check it up. There is some pressure gradient. 이걸 싹 셀라인으로 해서 베이스까지 다 맞추고. 베이스 다 맞춘 거지? Okay, as you can see, and there is a slightly pressure gradient, and looking at the hemodynamics, there is slightly the pressure gradient. At this moment, we can do the additional post dilation or something, and we will check it up the aortogram first. Okay, 요거지? 네, 바꿔주세요. 해놓고 한번 찍어보고 한번 또 디스커션도 약간 남았는데, 약간 그지? 오케이. 자, 줌하고 우리 포스 딜하게 되면 몇 미리로 해야 되지? 18mm. 자, we will check it up the status. Okay, and you ready? Push. Good. So I think a coronary space would be okay. We can apply the additional high pressure balloon using the 18, and then check it up the pressure gradient is remain. Okay, additional balloon 한번 더 해보자.
Yes. Actually, even though the procedure itself is very successful, but the final the aortic valve size may be small.
Yes.
And additionally, there is a 20 millimeters the pressure gradient between the LV and the aorta. Hopefully, this patient is not elderly, less than 80. So we do the post-AF.
Absolutely. Okay. So, and I think in this case we have a lot of debatable point, but our second case, SJ case, much complex. Different combination. This is tall in short. The second case is short in tall. Is coronary height very low.
For me, this is my interest is not procedure itself. What is the lesson for this patient? 75 years, small size and when we deploy the SAPIEN 20, and maybe we expect this kind of the happening in the future.
Yeah. I'll ask the Alan. You can protect the MK comment for SAPIEN valve 20. Okay, 좀 했지?
So using 18 or 20? 18?
This is 18. 18. Okay. 자, 이렇게 놓고. 자, 준비됐지? 자, 페이싱 온. 들어가나? 자, 인플레 쭉. 디플레. 다시 한번 하자. 페이싱 온. 다시 빠졌지? 좀 기다렸다가 조금 더 딥다이브해서 해볼게. 자, 여기다 천천히. 자, 페이싱 온. 자, 인플레 쭉. 그렇지. 자, 1, 2, 3, 4, 5 끝까지 갔어? 자, 디플레. 기다려. 자, 페이싱 업. 이거 그만 끝까지 다 집어넣은 거야? 좀 모질러? 어떤 것 같아? 근데 약간 들들한 것 같은데? 프레셔가? 저항이 느껴지는 대부분. 그래서 그런 거야? 한 번만 더 하자. 끝까지. 볼륨이 끝까지 안 들어.
18 or 20?
그럼 바꿔서.
I'm not sure.
Okay, we change the first resistance from
The inside the 20 is
자,
a 20.
페이싱 온. 자, 됐다. 인플레 쭉. 1, 2, 3, 4, 5. 디플레. 기다려. 자, 페이싱 업. 오케이, 됐어. I'm gonna change from the woman to man. 오케이, 여기서 빼면서 한번 보자. 자, 빼면서 자, 같이 보지. 1, 2, 3.
So, Dr. Park, this is Jeehoon Kim. So,
Yes.
how do you determine the balloon size in these cases? What was the criteria for that?
Yeah, so based on the absolute smallest inner size, IT side it's 18. Okay. Inner diameter is absolute 23. It's 18 was recommended. Yeah.
It's 23.
Okay.
Among that, the inner diameter of the previous APN is only 18 millimeters, so it would be quite stressful to go
Okay.
above that.
So, my question is, whenever you do some valve in valve, you have to concern about some possibility of coronary occlusion. So, in your procedure, you actually checked the aortogram, especially in order to look at the coronary safety. So, it was okay. Then you can be quietly, sure that this happening is not gonna happen.
Absolutely. Yeah, absolutely. So in the reason why before pre-dilation, I'm gonna checking aortogram, and that there was the space is suitable for the post-dilation. 깨끗하게 다 했지?
So whenever you see this going up to space, you can be sure. So you don't have to worry about it.
Yes.
Okay.
Can you see the hemodynamics?
Yeah.
So I think slightly better and still remained, but is acceptable. So I think this mean was just 5. Difference is direct pressure gradient by hemodynamics is 69 and the 65 is 4 difference, and I think this could be quite acceptable in this condition. So any opinion for the panel or the moderator? Do you want additional post dilation using the additional big size or any comment for this case?
For me, I agree with your opinion.
Yes, the systolic pressure is pretty high, so we want to lower the pressure a little bit too. So, but I think you're done.
한번 찍어보지. 와해주고. Okay, we're gonna check it up the final angio. 와해주고.
So here is, so my question is, here is already had the valve in place, which was implanted 4 years ago. That means a lot of some fibrosis and the tissue strengthening actually happened around the valve. In this case, why not, challenging with, the trying with the much more bigger size of the balloon?
Yeah.
Okay.
I might use a 20 to post dilate.
Okay.
Yes.
Push up.
18, because the
Yes.
inner diameter of the
Good.
20 actually is the TAVR valves are pretty close to the side, so it's 20 is the bottom, and the 23 is a 23 at the bottom. So
Okay.
I would go with 20 as not like additional now. This is
Okay.
probably fine, but I would
Previous
just
one?
use a 20.
So me too.
So as you can see, the aortogram, there was a coronary flow is okay, and still is coronary patency is absolutely okay. The position wise is as like exactly same level. At the bottom, the sapien valve is low level, and the absolute level is exactly matched, and the position is good. Although, and slightly remain is pressure gradient. I think this patient is 79 and is quite acceptable, and the supraannular valve type, and that is acceptable margin. So considering the patient safety, I think this result would be acceptable for this patient. Okay, any comment or?
I'd like to ask one question. For the history of the TAVR is almost to be more than 20 years. What is the percentage of TAVR in TAVR in the Asan Medical Center? What is the percentage nowadays?
Yeah, so we until recently we performed 3,000, and the overall case of TAVR in TAVR still less than 100. TAVR in TAVR case.
TAVR
right?
in TAVR.
Now, yeah, TAVR in TAVR. Now
It will
it's
be
slightly
increasing,
going
but
up.
so far,
Absolutely, yeah, absolutely.
so far, what
Yeah,
percentage?
It's I don't exactly. 우리 TAVR in TAVR total 몇 명이야? Yeah. Okay, we can check it up right now within 20 seconds.
Okay.
봐봐.
I think in the US is still
overall.
is getting more frequent, but it's still
TAVR.
not like an overwhelming number. So I think it is still holding in the sense that the longevity, durability of the valve is still
잠깐만 있어봐.
not bad. But I think these smaller ones may be a
전체에서
problem. So in Asia,
TAVR
you use a
TAVR
lot of
딱
20.
selection
That could be a problem coming up because we have not used 20 for a long time.
I think is the patient age is 85, and expected the
설마,
remaining
total 몇 개
life
중에?
expectancy is less than of 5 years. Why not? In that case, is the small size of the sapien is good.
Having 20 case. It's until recently we performed among our database 2,400, and the TAVR in TAVR just 20 case.
Yeah, that's about
just
right.
20 case. Yes.
Around the 1%.
Yeah, right.
Okay.
I expect it's much going up.
No, yeah. Great, thank you, Dong-Woo. Great case, and thank you very much for, again, doing all the cases.
Okay.
And,
Thank
no
you.
problem.
Thank
Thank
you.
you very much. See you later. Yes.
Thank you.
job.
Thank you very much. 이 케이스 저기
Let's go over to SJ and to Jung-Min for a very, very complex TAVR, as Dong-Woo was saying before. So
We are ready to enjoy your very excellent, complicated cases.
Right. I hope you can enjoy, continuously. And really, thank you for joining us in the late afternoon today. It's almost, final cases. Just Duk-Woo told you this is really tough cases, risky, and so I would introduce Dr. Jeehoon Kim. Actually, he's the first operator. Just like Myeong-Ki second operator, and Hansu, Dr. So, Dr. An, you know that. They, An is here, he's also here. The reason why, he worry about, I am here. Even in the nurse and technician, they are all, worry about it. I'm here, so I cannot agree there. So I have to be here. Anyways, we'll start with the really tough cases, and so we have lots of discussion point, right, Dr. So, would you please stay on?
Yeah, thank you for your introduction. I'm Kyung-Won in Asan Medical Center. Let me introduce this case. 87-year-old female was admitted for dyspnea, and she underwent the TAVR procedure using Evolut 26 mm 7 years ago, and received the PCI to lab mate to proximal LAD 2 months ago. And her BMI was 22.2, and calculated STS score was 16. Baseline EKG shows LBBB, and chest PA shows no significant lesion. Echocardiography shows functional moderate MO and eccentric severe AR and moderate LV dysfunction. And transesophageal echocardiography shows eccentric AR, valvular AR.
That one?
Yeah.
All right. Great.
And this is the electrogram of a previous implanted valve. So based on CT findings, base of valve node 1 area was 376, and below the LCA level, node 3 area was 366, and at the level of LCA, node 4 area was 375, and node 6 area was 354. The coronary height of LCA was 13.7, and RCA was 14.4. There are severe calcification in peripheral arteries, and minimal diameter of femoral artery was 5 to 6 millimeter. And this is the sizing table for SAPIEN 3. At the level of node 4, if we use a 20 millimeter valve, the valve to LCA distance was 2.7, and when we use 23 millimeter, the distance was 1.7. So we planned the TAVR procedure to node below the node 4. And this is another case 1 year ago, who are in the similar situation. When we, in this case, we used the SAPIEN valve to Evolut valve. So this is our final plan.
23. Okay. Anyway, so finally, you've seen the previous cases. Maybe Dr. An had performed. Would you show us again? There's the cases is mainly, AR, right? A severe AR, and actually peak velocity 2.4 is not, a serious aortic stenotic component here, and so issue is we don't actually touch it too much about the, native, evolute out valve, and we want to place a little bit lower position of SAPIEN. Kind of you explained the node 3 and 3.5, something like that. And so, Dr. An, would you explain that experience about? You have no, all right. Dr. Kim, you have mentioned about the presentation, and then we discuss about it.
Yeah, the primary mechanism of this patient is aortic regurgitation. So actually, over the last 6 months, she was admitted to outside hospital twice for a heart failure symptom, and the
ejection fraction 44%, right?
Yeah. And the reduced ejection fraction, and then LV enlargement, and severe aortic regurgitation. So we want to fix the aortic regurgitation with valve-in-valve procedure. But as you can see before, the risk of coronary obstruction is high, so we want to avoid the coronary obstruction.
In terms of, you mentioned about the distance from the device to the coronary ostium. Is how do you have that one?
Yeah. When we implant the SAPIEN valve to node 4, valve to coronary LCA distance was 1.7.
1.7.
Yes.
Very shallow. Actually, the height is quite enough. It's 13 something. However, already in valve implanted, actually, you know that the valve itself is relatively high, right? Supra-valve structure. Anyway, degenerated, organized. It's quite close with the, coronary ostium. So, personally, I think it's a second procedure for, TAVR. I think it will be more, For particular, if the patient had a, stenotic component is more larger, tighter ears, right? You have to do something more, right? All right, Alan, would you discuss them?
Yeah.
It's very tough cases, really.
Maybe I ask a question, where exactly is the left coronary taking off relationship with the previous evolute valve, meaning what node does it actually come out from? Can you tell? Meaning that
The coronary risk plane is around 13.
13.
So it's just below the node 4 of the previous
Just below.
valve.
All right.
Right. So you are basically thinking about, obviously for AR, you can implant a new valve relatively low, because you're not covering the previous valve. You're just basically going to have two valves in sequence,
right?
And one is to prevent the regurgitation. And so, if the risk plane is between node 4 and 3, if you can get to 3, then you may avoid coronary issue with that.
Actually, the main component is stenotic component is more degenerative, particularly over there.
But there's AS as well, right?
Well, you have to think about another modification of the valve itself. It's a basilica, it's just, yesterday you've seen the uniform, the shortcut, something like that. However, fortunately, anyway, the main component to be the main AR, and so we're gonna. Any discussion point over there?
Will you do the coronary protection in this patient?
We did a coronary protection.
Okay, would you show us the next view? All right.
It is easier or not easier? This is
easier, right? Technical point of view, he can do.
You have to be very objectively. Many of the physicians worry about that after the evolute valve deployment, the next PCI procedure is very difficult. So that is the common concern. But what about in this case? Is easier protection?
If you will have the air to them in detail, right? Cautiously, actually, you can clearly see that line of valve, inner valve, degenerate valve is almost, same line with the left coronary, ostial part and so on.
Yeah.
Okay, anyways,
you freeze the picture, maybe make a still picture. Sometimes easy to count the notes if you pause the run, right? Because it's moving, sometimes get very confusing. So we take 1, 2, 3. So the third note is actually below the coronary. The fourth note is kind of where the coronary is, as you said before. So if you implant it relatively low, then you can avoid a coronary issue. The right is higher, I think, right?
Yeah, right coronary is higher than left coronary.
17 something?
Yeah.
So we didn't worry about that. We don't. All right.
Alan?
Sapphire wire, so be careful, right?
Yeah, hi.
Okay, we're going to do directory.
Dr. Grube has a question or
No,
comment.
I don't have a question, I have a comment.
Comment.
I think the good news is that this is not calcified, because calcification would make the placement much more difficult. And I would go inflow over inflow. I don't think you have to worry about the coronary, because obviously there is flow now with the previous evolute, and the sapien, if you go inflow over inflow, has the large cells across from the coronary. So I think the sapien is an excellent choice, and I would go inflow over inflow.
Okay.
So
What size of the sapien?
Flora?
23.
23? Okay.
Well, if I just add one more comment, if we're using
Okay,
a
what's
Sapien 23, the height after the deploy would be 18 millimeters.
All right,
So if it were
Yeah.
below node 4, then there would be no
Preparing.
interaction with the corneal ostium, fortunately.
So one of these, sometimes have to be very careful when you cross the evolute to deliver something. Sometimes you actually end up in and out of a cell in your wire, and you try to deliver a bigger thing, now it won't go, right? So I a lot of times test it with a balloon, making sure the path is clear before sending a valve in. Because sometimes you think it's okay, but it's actually wire out, in and out. Now then you're kind of all very difficult.
그래요?
좀 더 해줄게.
So an
No,
extra
no, no.
step, but
So
at
you're
least
gonna
kind of test the path with a balloon.
Flora.
코플라마.
I think this might be better, right? You're gonna push out there. It's too low. Slowly. Hurry up too much. Actually, this is a little bit lower than the quality, osteal line. So
Right.
what do you think, Dr. An? Is it okay?
Yeah, okay.
A little bit
little bit
further,
lower,
push,
maybe.
push it back, push out a little bit. So we're gonna make a little bit more coaxial. That's the point. And maybe neither. Here we are.
A little bit higher.
A little bit higher. In terms of quality osteal level, is it pretty enough to below that the one, right? What do you think?
It's too high.
Okay.
It's
It
okay?
could be an accurate position.
All right.
There is some possibility of the crossover.
Good. What do you think? It's okay?
Yeah.
All right, pacing.
잘 잡고 있어요.
Facing on.
Yes.
Is it okay? Inflate.
Inflate.
Still getting up.
Face off.
Right. We located a little bit lower. So, however, it is pushing up in a part. To pull back the wire a little bit further. Wire today. I don't like it. Okay. Just.
I think in the valve case, at the time
Ready?
of the inflation, there is some forceful moving.
Right.
Because
So we.
space was occupied.
All right. Car is okay. All right.
한번 코너를 가까이서 찍어봐봐. 가까이서. 저기 가이딩 사정 붙여서.
가이딩으로 한번.
Much improve. First of all, the ECG finding there is so far no S elevation. Okay.
있어 보인다. 그죠?
What do you think? It's good.
No problem.
It's really good luck, right? We want to play a little bit lower position of sapien, right?
Yeah.
One segment is actually,
Elevation,
right?
yeah.
For the lowers, however,
Yeah.
the device is pushing up.
Although we are intend to proper position during the inflation is forcefully is going up, going down. There was a
What is the
real issue
lesson
about
of this case
valve.
is even though SCA bar does not very perfectly accurately position the valve.
Right. This
So
is
we
part
have
of
to be more safety margin.
Yeah, absolutely.
What do you think anyway? Coronary, left coronary flow is good.
Pressure gradient.
I'm happy. Its result is personally I think is perfect.
Yes.
I hope so.
I mean, it's hard to deploy low. That's the problem. That is is
So,
not easy to
would you-
sort of
would you
go against
confirm
what you think is
coronary,
inflow to
yeah,
inflow.
and
That is kind of the
Confirm.
natural.
Again, and then we're going to pull back. Right?
But to put it half a cell
저
lower,
프레시 한번
and,
재보고 있다. 프레시 양쪽.
easy said than done.
코로나리 어디?
둘 다 찍을게. 인젝터랑 둘 다 레디 해줘.
야, 오케이.
coronary angioflow.
엔지오부터.
Okay.
코로나 엔저 먼저.
Injection.
Okay. Yes.
I think it's
yeah.
good, right?
Coronary,
Right.
Yeah.
coronary, left coronary ostium seems to be okay. Yes. And,
Coronary flow is okay, right?
yeah. Pressure gradient. Can you measure the pressure gradient? 양쪽 깨끗하게 해서.
All right. So AR component is definitely
Yeah, but,
disappeared and 저 코로나리는 나오죠. 코로나리 수를 빼고.
So, and one of the issue, if you do TAVR TAVR procedure, there would be some new pressure gradient because of, second valve, small valve. pressure gradient 한번 재고. 한 얼마지?
I think it's perfect, right?
Yeah.
The AS component is very
Yes.
negligible and
Mean
the
difference
AR
is-
component decreases.
It's okay. It's just
Alright.
three. Yes, good.
코로나리 catheter is out. And then we're going to do air 2 gram, right? All right, now, slowly.
와이어 빼고.
Be careful. All right. All right.
이렇게 놓고.
Picture.
인젝터. ready?
Air 2 gram.
Yeah, coronary flow.
The most difficult cases.
May I have one question more? If there is something happen in the coronary artery, there is lipid cannulation is do you think about the lipid cannulation in this patient?
Yeah,
left coronary artery.
So, however, anyway, we confirm the coronary floors,
Yeah,
so the air flow.
Coronary flow is
case,
perfect.
Yeah, if coronary obstruction happen, we would like to do recannulation. Is a new valve upper cell, usually okay. And then we negotiated something, and either just avoid the chimney stenting. For this position we can do new cannulation by upper cell of a satin valve.
Air 2 gram.
No, looks good. I mean, there's enough space between the valve and essentially can go
Oh,
around
right, good.
the previous valve
Yes.
into
Do you
the coronary.
do you want to see another view?
아래, 여기 한번 딴데 이런 아래 뷰나 이런 거 한번
I know, I know.
아래
Okay.
뭐 앵파스 뭐 이런 거 잘 펴졌나 보네. 이게 잘 안 보인다. 다 겹쳐가지고. 아래요, 오케이. 이 정도에서. 이거는 뭐 앵파스 뷰가 이게 안 보이겠다, 그지? 오케이.
So Dr. Yeung, so sometimes the coronary occlusion can occur after several days, after the procedure. So
Absolutely,
how do we,
absolutely.
make
That's
sure,
correct.
immediately post the procedure by looking at the
Would you show us
angiogram?
previous?
Because the angiogram, the flow is imperfect, right? Because it's hard to know
Yep.
is the flow normal.
All right.
Yeah, that it means the dye goes
There
in,
was
but is it
there was some space. Yeah.
right?
So usually coronary sequestration case in the upper part exactly, no space. This patient has some space. Yeah, coronary flow is okay. Yeah.
All right.
The valve is pointing straight forward, so there's gap and there's lesser curvature for the blood to
Yeah,
go down.
absolutely.
And
Yeah,
sometimes I
absolutely.
get a CT, just making sure that it has enough space
Really?
in three-dimensional way.
All right.
Great. Yep. Go ahead, SJ.
I want to introduce, Dr. Kim, Jeehoon Kim is our last junior, and he will get growing and sooner or later. And you may know that how many, they are really worried about me. I'm sorry, however, I'm very happy to get the, high risk BIV cases. So maybe in the next TAVR, right? Future perspective.
TAVR,
This is the
TAVR,
main
absolutely.
issues, TAVR in the TAVR in SEOUL, something like that. However, you have to realize, so when you choose the device concern, right? I got some bias, and so I don't want to talk too much about that. And so you have to think about the second procedures, after the valve failures, we have to, consider about the coronary access and another, second device or something like that. And so,
And we also discussed this patient, and if this patient, the main component was AS, much complicated. AR is we targeting node 3.
main
AS,
component is
AR.
you have You have to do that.
Yeah.
Yes. Right.
Yes, absolutely. We require something is a Lipland modification, basilica or shortcut, and just a good plug is AR dominant that we try to the node 3, the upper position. Although, as you can see, the last invasive hemodynamics mean pressure gradient 3 is just acceptable. So our case, we did additional balloon using 20 millimeter and before 20 millimeter and the mean pressure gradient 5, even 20 is 4, just 1 millimeter is decrease, and the 3 and 4 pressure gradient is acceptable. Yeah.
Anyway, other small things. Anyways, you got to place a little bit lower. So however, it's a push up and during the inflation and so on. It's happening usually. All right. Alan, anything?
No. Again, thank you, you and the whole team, Dr. Duk-Woo and Jung-Min and everybody else for really an exciting 2 days and taking this relatively straightforward TAVR to more complex and more complex and more complexity. And I think the TAV and TAV is always a challenge, especially if the first valve was sort of placed in a funny way or difficult way. So thank you again for all these great examples, and appreciate all the teaching and illustration of difficult situation. Thank you.
Thank you, Alan, and every audience. And next year we will prepare much complex TAVR and TAVR case.
No, next year will be TAV and TAV and TAV and TAV and TAV and TAV.
Okay,
thank you.
Risky situation.
Yeah, thank you. Thank you. Have a good day.
All right. Thank you. Thank you for next year.
Thank you.
Thank you.